So delirium, first we're going to define the differences between delirium and dementia. So delirium is an acute onset. It can be caused by medications, dehydration, hyper and hypoglycemia, thyroid disorders, surgeries, or stress. The main difference in delirium is that level of consciousness will be changed, and it also affects poor short-term memory. Patients can be either hypoactive or hyperactive, and this condition is reversible. So potential causes of delirium, it can be from fluid and electrolyte imbalances, which can be caused from congestive heart failure, again, hypoglycemia, hypothermia, calcemia, and then also issues with the thyroid gland, and decreased cardiac function can also affect the causes of delirium, and renal function. Issues with the central nervous system can cause delirium. Emotional stress, pain, malnutrition is also a big cause of delirium. Hypotension and infection. So a lot of patients with UTIs get confused. So that is an example. So dementia is a slow onset. It is caused by damage to the brain tissue due to Alzheimer's or other degenerative changes. Later on in the presentation, we will talk about the different types of dementia. There's quite a few. So with dementia, it not only affects poor short-term memory like delirium, but it also affects the long-term memory. The level of consciousness, though, in dementia is normal. Patients with dementia, they will experience inappropriate behavior, unsteady gait, uncoordinated movements. In a lot of dementia patients, the inappropriate behavior is very evident, especially at night. The issues with dementia are irreversible. There is no cure currently, just medications and things that can slow the progression of the disease. This, if it loads, hopefully, is just a short video that we liked. It is a mnemonic for remembering delirium versus dementia. It's OCD camps. So it's only about 2 minutes, but it helped kind of stick that information.
Okay, so in this video, we're going to be talking about the differences between dementia and delirium. First of all, delirium is defined as an acutely disturbed state of mind, characterized by restlessness, illusions, and incoherence. Bear in mind, though, that this can be associated with hyperactivity as well as hypoactivity. So what is the difference between delirium and dementia? The mnemonic we're going to use is OCD camps. The O stands for the onset, which is typically rapid in delirium, within hours to days, while in dementia it's over months and years. C is for the course. Delirium is often fluctuating, meaning the patient may be quite settled at some points and more agitated in others. Typically, there's the sundowning phenomenon, where patients with delirium become more agitated towards the evening. In hypoactive delirium, this is harder to appreciate, however. Dementia, on the other hand, gets progressively worse. Next, we have D for duration, which in delirium is mostly days to weeks and is reversible, although it can last months in causes such as liver failure. In dementia, the duration is again much longer, months or years, and in this case is irreversible. The second C is for consciousness, which is usually altered in delirium, while in dementia they can be clear, although of course this can be affected greatly in dementia too. A is for attention, which again can be altered in both dementia and delirium, but in delirium there is a significant impairment typically present, while in dementia the attention may be somewhat normal, given that overall dementia is mostly associated to memory loss, while delirium heavily features a lack of concentration and inattention. M is for memory. In delirium, the immediate recall is usually impaired, while longer-term memory may be quite good. In dementia, however, the immediate recall is often normal. P is for psychomotor changes, which, as we mentioned in delirium, can be hyperactive or hypoactive, whereas in dementia, psychomotor disturbances are not usually present. Finally, we have the S for sleep-wake cycle, which again can be altered in both, but is often significantly different in delirium. Often a complete reversal of the sleep-wake cycle is present.
So that was just a little mnemonic that was kind of helpful.
All right, so for Alzheimer's disease, that is the most common form of dementia. A lot of times people forget that Alzheimer's disease isn't its own entity. It is one of the most common forms of dementia because, again, like the video was discussing, it is progressive and it's not reversible. It's categorized by two changes in the brain, neuritic plaques and neurofibrillary tangles. The neuritic plaques are the B amyloid protein fragments and they accumulate in the brain, forming like plaques or plugs, and those lead to neurodegeneration due to inadequate clearance of the plaques in the brain. Versus the neurofibrillary tangles, those come from the protein tau, which forms insoluble twisted fibers inside the brain cells, and these create misfolded tangles that progressively build with time, leading to cell death. So the difference between the two is basically like their location. The tangles are on the inside of the cell itself, while the neuritic plaques are on the outside, but they both lead to neurodegeneration. And here's a picture showing the differences between normal and Alzheimer's disease. The tangles are highlighted and the plaques are highlighted as well. And possible causes, it is believed that a combination of genetic and environmental factors influence the predisposition of Alzheimer's disease. And as we see very often, it tends to run in families. There's abnormalities to chromosomes 21, 14, and 1 that have been identified, and those lead to the production of the abnormal proteins that we just spoke of. And so they do sometimes see a connection with chromosome 21 with the Down syndrome and with Alzheimer's disease, but it's not 100% correlated. And there's also the idea of possibility of free radicals that cause oxidative stress and damage building up in the brain, as well as higher levels of mercury, aluminum, low levels of zinc have been noted in majority of Alzheimer's patients. But again, there is no current correlation that exists to establish this causation. And here are some signs and symptoms of Alzheimer's. It is progressive, so it develops gradually. Typically, the first sign is difficulty remembering new information. They get disoriented, confused. They have behavioral and mood changes. They have newfound paranoia to people and places, and they have worsening memory loss. So they have continuation of mental decline and cognitive impairment. They also have increased difficulty ambulating, swallowing, and speaking. So safety is a huge concern. And here's just a chart that shows those progressions of signs and symptoms. And this is actually in our book, but I really like this because it breaks it down in terms of being able to compare like normal baseline versus like beginning Alzheimer's and just the different phases. So you can see as those keep worsening, how the patient becomes more dependent and loses more functions. And then for the Alzheimer's management, currently we know we can't be prevented or cured, but there are medications such as donepezil, rivastigmine, and galantamine that are used to stop and slow down the enzyme acetylcholinesterase. And there are clinical trials that are currently being conducted to find treatments to improve the function and slow the disease progression. There's actually a lot of funding that's being poured into these studies currently. There's also research in estrogen, antioxidants, and anti-inflammatory agents, nutritional supplements, gene therapy, and vaccine development that are also being investigated.
Okay, so some of the other types of dementias that Amber mentioned earlier were listed in the book. I mean, there were only 3 different types listed in there, but I'm pretty sure there's more than that. So there's vascular dementia, and that is it's essentially you have cerebral infarctions that can result in localized and then progress to diffuse damage. When compared to Alzheimer's, it is more rapid in its progression, but it's more predictable. You have an increased risk if you have a history of hyperlipidemia, hypertension, smoking, if you're sedentary, or if you have a history of stroke or cardiovascular disease. Another type of dementia is the frontotemporal dementia, which is also known as Pick's disease. And in this one, you actually have an atrophying of the frontal lobe. So what's different in this one when compared to Alzheimer's is that you have more behavioral abnormalities, whereas some of the in the early stage of Alzheimer's, you might have, memory slippage, but this one is more, you have differences in your abstract thinking. You'll have your speech and language skills will kind of diminish first. And then another type is Lewy body dementia. And so this one, it's abnormal protein deposits, which are known as Lewy body plaques. They gather in the cerebral cortex, and this one's really devastating. It can cause their mental status to fluctuate rapidly. When they do get sick, they get really sick. And interestingly, they have an idiosyncratic reaction to cholinergic meds. So like your sedatives or your antipsychotics, it'll actually have like an opposite effect than what is expected. So another one on here, it's kind of not a type of dementia, but it causes dementia. And it's listed in the book is I don't know how to say this, Creutzfeldt-Jakob or Jakob. I think it's German, but it's an extremely rare brain disorder that, like I said, causes dementia. And it's super rapid. And with this one, you have, it's a super rapid progression, and death usually happens within 1 year of diagnosis. So with this one, you have, a lot of like behavioral issues. You'll have psychotic behavior, emotional lability. They'll lose function in their muscles. They'll have muscle spasms and even seizures. And that it's listed in there as extremely rare, but my maternal grandfather actually died from this. So now you can say you know somebody, but okay, next.
Okay, so caring for patients with dementia, special care is required due to the negative consequences, not only for the people, or the person, but also the families. And a large part of the treatment falls into the nursing scope of practice. And I myself have personally gotten more comfortable just being exposed to dementia and Alzheimer patients at clinical. Next. Ensuring patient safety is one of the most largest considerations that you need to be aware of when you're taking care of these patients. Poor judgment and misperceptions can lead to serious behavioral problems. A safe, structured environment is essential. The people and components of the environment should be consistent. So a lot of times, if the same nurse that's normally taking care of a certain patient and kind of knows the routine of them, that's a recommendation. And then you can use items to trigger memory. For example, a photograph of the patient, a consistent symbol, something that you can put on their door, even personal possession, and then noise, activity, and lighting levels can be overstimulating to them, and it can decrease their function more. So got to reduce those. Next. So sundowner syndrome, like the question on our exam today, it's nocturnal confusion, and basically got the name because of after the sun goes down. That's typically when these like signs and symptoms present, almost just like worsening. Risk factors are like an unfamiliar environment, disturbed sleep patterns, use of restraints, excess sensory stimulation, sensory deprivation, change in circadian rhythms. And yeah. Okay, so the prevention and management of sundowner syndrome, just the kind of just keeping that familiarity as much as possible with the patient, providing physical activity as tolerable, like as the patient can tolerate, to help expand the energy. Again, like I said, just keeping, not overstimulating with the light. So just make sure like there's a night light for them, just in case like they did get up, but just it shouldn't be pitch black, but it also shouldn't be like super bright. Yeah, the night light, touch, if you know that person is accepting of touch, because it may calm down the person, and just reduce the stimulation. So, reducing noise, and then just make sure all of the personal basic needs are met. So for early dementia, like occupational therapy and expressive therapy is offered, and it can be like beneficial for them. And the reality orientation is basically like daily like group therapy, and it can even be as simple as just like reminding, the patient of like their name, even like every time you encounter them. Late therapies for dementia, listening to music, petting an animal, touching various objects, and being touched is like very pleasurable and like a stimulating experience for them. And yeah, so that's about all that. And then this is just something that we found, like therapeutic communication kind of, and just like tips for dealing with with a person with dementia. So, be clear when you're communicating, get their attention softly. Don't, scream across the room, like go up to them. Make sure that they understand your questions. So clear speech, not super aggressively long words. Be patient. Don't point out their mistakes. And then don't put them in stressful situations. If you could tell that they, are not enjoying something, that can, heighten the dementia and just not be good. So just like to keep them calm in calm situations. So next.
So following safety, the next most important thing for demented patients is to provide physical care for them. Because they're demented, they don't always remember to treat their basic needs. So you want to make sure you have them on a consistent schedule. You want to make sure you're giving them breakfast, lunch, doing certain activities around the same time every day. You also want to be consistent with their caregiver, or if they're also in like a facility, you want to try to have consistent nurses with them. So when things are not the norm, they don't get more demented than usual. Patients can sometimes complain that they're hungry or forget that they finished their meals. So we need to remember to feed them. With water, they may forget to drink, so they become dehydrated. And already with the age-related changes, it's easy to become dehydrated. So on top of forgetting to drink, it's that much more of an issue. And then you want to make sure you maintain the patient's hygiene. So you want to make sure you're bathing them, grooming them. Even though they're demented and forgetful, they still like to be upkept like any other regular patient or person would. Next slide. There are some complementary and alternative therapies that can be used to help with dementia. Some nutritional supplements like the vitamins B6, B12, C, and E, folic acid, zinc, and selenium are important. Some of these meds are known to improve memory, circulation, and oxygenation, and that can help slow down dementia or anything to happen. And then there's the herbal remedy, ginkgo biloba. That's known to help improve memory, improve circulation, and mental functions. And it's been proven in some clinical trials that that does have benefit. We want to be cautious, though, when patients are taking these herbal remedies to decrease that it has an increased risk of intraocular hemorrhage, subdural hematomas, and if they're taking anticoagulations with the concurrent use of ginkgo biloba and anticoagulations, they could be at increased bleeding risk. And then it's also important as nurses, when you see that patients are taking this and they have a list of medications, you want to encourage them just to talk it over with their provider to make sure there's no contraindications or they could be at risk for other things. And then there's also Chinese medicine that's known to help with treatment of dementia. So in combination of the herbal and the nutritional supplements that I just mentioned, they also do a therapeutic exercise called Qigong, and this is known to improve brain oxygenation and visualization. And then the image to the right just shows like the exercises, and they just really concentrate on doing deep breathing, and that's what really improves the circulation along with the supplements. Next slide. So ultimately, when we're caring for demented patients, we want to respect our elders. With any patient, you want to have respect for them, but it's easy just to get lost and get angry and like lose your feelings when you're doing a busy shift and you know things could be done faster if you were to do it versus the patient. But we really want to treat the patient as an individual. We want to get to learn about their personal history, their personal life. It's good to have them share stories from the past, and it makes the patient feel better and more as a person. We want to promote their independence. Like I was saying, our task could get done faster if we were to do it ourselves, or even the caregiver was to get the task done themselves. But we really want to promote the patient to do their own activities if they remember how to, and if not, we can always guide them through dressing themselves and doing all their self-care, prompting them to brush their teeth, eat their food, and just to go through the mechanics of that. We also want to promote the patient's freedom. With dementia, you have wandering dementia patients. So in addition to safety, with that being the main concern, we also want to give them two options of things. So we can implement this by food, like what do you want for dinner, this or another option. And if the patient comes up with their own option and we're able to do that, we can always implement that to make them feel special. We can also, maintain the patient's dignity. So as a provider, it's easy to become angry, or even some of the demented behaviors may seem odd to the normal person and we could laugh at them, and that can make the patient feel ashamed, but they really can't help everything that's going on. So we just want to remember as healthcare providers that how we treat a stroke victim that really has like ambulation issues, and if they were to fall, we wouldn't laugh at them just because we felt. Like we would treat them with respect and help them, let them know it's okay, try to prevent the accident from happening again, and implement other activities to help them promote their individuality and independence again. We should also remember that they're people too, so we want to dress them in attractive clothing, give them the option to pick out their clothes. They still have a personality. We want to give them good grooming, give them adult hairstyles, also keep up with the grooming of their hairstyles. So in the nursing home, like people would come in and give haircuts and just keep their upkeep. We want to address the patient by name, and then also maintain their confidentiality and their privacy altogether. And then implementing all of these, it should also make it really easy to connect with our patients, really get to know them, and it would be easier with their routine habits that we instill in them, getting to know them personally, that when things are off, it's easier to identify like, okay, this isn't the patient's norm. Like, I know they're demented, but like this is off for this individual. Next slide. And then this is just a quote that we found to respect your elders, learn from the people who have walked the path before you, respect them because someday and sooner than you can imagine, you're going to be old too. And then nursing is holistic. So again, focusing on the patient and making sure everything's okay with them. We also want to provide family support. So we want to assist the family with physical, emotional, and socioeconomic burdens that can come caring for a cognitively impaired patient. We also want to review the basic care needs to even special care techniques that involve taking care of the cognitively impaired patient. So we want to review like lifting patients, bathing the patients, everything that's basic that we think that you should understand to do because you do every day with yourself, but caring for someone else is different. And then if there's any special care things that need to be provided for the patient, if they have other chronic conditions, they may have injuries that occurred just from being demented and injuring themselves. We would teach them how to do like wound dressing changes and how to keep, how to watch for signs and symptoms of infection and maybe that it needs to be looked at again. And then we also want to prepare their family for the emotions that are accompanied with caring for the client. We want to let them know that caring for them is a big responsibility and a burden, so it's okay to feel certain ways, and we just want to communicate with them therapeutically. And then also let them know that all the changes that the client is going through, that they may not always act the way that they used to know them, and it's going to be a constant adjustment, just trying to care for them. And then ultimately, after talking to the family therapeutically, finding out their needs, we can discuss needs for support groups and counseling options if they're needed. And the Alzheimer's Association could also be a good recommendation to refer patients to.
Okay, so our patient case, this was a patient that Mira, Amber, and I got to spend the majority of a day with. She was a 95-year-old white female. She was admitted to the John Knox with her husband, but she was admitted with the diagnosis of Alzheimer's and dementia with behavioral symptoms. And her health history includes AFib, anemia, hypertension, hypercholesterolemia, and her surgical history includes a pacemaker and a hysterectomy. Her only allergy is a leaf. You can go next. So these were her active prescriptions when I was there. You can see she's on the donepezil for her dementia. She's got a couple different cardiac meds, like the metoprolol, the other stuff you can see there. But she, oh, you can go to the next slide. So she was really interesting, and it was actually really surprising for me, at least, when I found out that she was 95, because I mean, she was in a wheelchair, but she was very mobile. She was just scooting her way around the unit, just going up to people, saying hi, talking to everybody, and she expressed the interest in wanting to go outside. So we asked the CNAs if it would be okay. So the three of us, we walked her around. They have a cute little courtyard. And she was like, oh, I would love to go outside and get some sun on my, or get some sun and get my cheeks nice and rosy. And so we got to take her outside and we sat and talked with her for a little bit. And I mean, this was all before we had looked at her chart, so we didn't really know what her diagnosis was, but we were on the memory care unit, so we knew it had to do something with dementia or Alzheimer's, but through talking with her, it really wasn't evident that she had any sort of memory deficits. She was asking us questions, oh, are you guys in school? Do you have kids? What do you want to do? And she was just very with it. And the only clue she let out was, I think she repeated 1 or 2 questions throughout our entire 30-minute conversation. So she was, I don't know, it was surprising to me once I read her chart and saw that. But that she was there with her husband, like I said, and her husband was considerably worse off, but it was kind of interesting to see the way she took care of himself as well as herself. And I guess that level of competence wasn't really what I was expecting. So it was definitely eye-opening. Granted, we spent the daytime with her, so I don't know how it is if she experiences the sundowners or anything like that. But yeah, it was definitely an eye-opening experience. That just because you read about the symptoms in the book doesn't mean it's always the way it's going to be. You can go to the next slide. And this is our reference, which is the textbook. And then we also have a Kahoot for you guys, which I think Amber's going to pull up.
All right. Slowly but surely. Sorry, guys. Is it showing?
Yeah.
Okay.
Anybody else?
All right. I'm going to start it. Okay, so this one, dementia alters a patient's level of consciousness, is false. It's delirium that alters the level of consciousness. So dementia does not. All right, good job, Hi. All right, almost everybody got this one right. It is true that sundowner syndrome is classified as nocturnal confusion. Sleep, please, I agree. Good job. It is irreversible. So it's a tie, but it's actually false that delirium is an irreversible condition because delirium is reversible. So yes, this is true. It's very important to complete a comprehensive evaluation before diagnosing somebody with dementia, because again, like delirium, they could be having an infection or an electrolyte imbalance, something else going on causing that memory issue. So this one is false. A person with dementia is at an increased risk for suicide in the early stages when they're more aware of the changes that are occurring. Yep. Yes, so this one is true. These patients usually have normal memories with behavioral outbursts, language disturbances, visual disturbances, and they often lose the loss of limb control. And a lot of patients with this diagnosis of hippocampal sparing Alzheimer's disease weren't diagnosed until they were found on autopsies. Yep, there's no prevention or treatment, just medications to slow the progression. Yep, this is true. So this is false. Frontotemporal dementia is also known as Pick's disease, and it's behavioral issues before cognitive issues. This is true. The patients often are misdiagnosed and they decompensate rapidly when they are ill. Yep, this is true. Yep, this is false. Trauma and toxins, they do contribute to the development of dementia, not just delirium. And the final question So this is true. It's Creutzfeldt-Jacobs disease. I don't know if I said that right, but it is a rare brain disorder. Remember that it's a rapid onset and death with in a year typically. So very sad disease. And I think that is the end.
What a great presentation. Awesome presentation group. So class, got some questions for this group in reference to delirium or dementia. Both of these are very much things that we look at with our older adults. And so it's real important that we understand how to take care of those patients. So I think this is an excellent presentation. It brings out a lot of great detail. So what kind of questions would you ask this group? No one has any questions? Be sure y'all know this material. It's really, really good. Excellent, an excellent job. So speak up, but I have a couple things to talk about. I really like that mnemonic video. That was really cool. The OCD camps. Yes, that's something that it would be well wise to learn, right? Because that would be very, very useful in distinguishing the two conditions. Very good. I do enjoy that you are very in-depth, but not overwhelmingly, because, you know, mental health conditions, particularly these two conditions, have so much information that we could learn, but you brought out the highlights, but yet it was in-depth enough to make it really clear on what we should do. And I really liked all the nursing actions and the interventions that you brought out, because that's what we as nurses really have to know. Because even if you're in the hospital taking care of med-surg patients, you may very well have a patient with Alzheimer's or some other form of dementia, or even some delirium from medications. So we still need to be able to take care of those patients regardless of whether we're working in a psychiatric area or a psych ward. That was very good. Would you go back, group, to that, your Alzheimer's figure? It's that one that showed the different stages of Alzheimer's, and let's do a little bit more discussion with that. Kind of walk us through that chart. Would you mind doing that?
I'm opening it now. Give me 1 second. Sorry.
Perfect.
Just
That's really a good chart, class. It's wise to get to know this chart as well.
Was it the one with the mountain, like the progression?
Yes. It's called The Stages of Alzheimer's Disease. It was from your textbook. And I think it's a really, really good one. So kind of talk to us, take us through this process.
Did you want to do it, Mira, or do you want someone else to do it? Was it your slide?
It's fine. I can cover it. So stage 1, normal adult, you know, where everybody is baseline. So there's no impairment at this stage. And second stage is the normal older adult. So this is before they get diagnosed or have an official, you know, diagnosis for this condition. They will have self-report of memory impairment, but no objective cognitive impairments noted. So I think they start to believe that they may have it, but there is nothing objective yet to show us the progression of the symptoms. So at that point, we're still considering them like a normal adult. We're not saying like they have Alzheimer's dementia yet. And then at stage 3, that's compatible with early dementia. And that one, basically, they start to have those cognitive impairments recognized by other people. Usually it's family members. So they get anxious, they have impaired performance, especially with situations that are very demanding and that require them being into like larger social settings. So at that point, you know, they're having early signs of Alzheimer's dementia. And then in stage 4, they have mild Alzheimer's dementia. And that's when they are starting to show signs and symptoms of withdrawal, denial, becoming more depressed, inability to perform their ADLs. And of course, that contributes to the depression and not being able to perform complex tasks anymore, They become, they have a flattened effect, which goes with the depression. Their cognitive impairment starts to decline, and it becomes more evident when we're examining these patients. And then for stage 5, which is moderate Alzheimer's dementia, that is when they become more disoriented to time and place, and they need assistance in clothing selection. So like a little more help in their ADLs. For stage 6, for the moderately to severe Alzheimer's dementia, that's when they forget the names of their spouses and other family members. Personality and emotional changes start to become more evident. They have the inability to perform many of their ADLs. They're agitated a lot of the times, and at this point, like, they're very, very dependent. And then stage 7, which is severe Alzheimer's dementia, the last stage, that is when they have loss of verbal and psychomotor skills. They're the ones that we see that are just sitting around slumped. They're not communicating with anyone. They have incontinence, and they're a total assist. They're completely dependent on us for all forms of care.
This is excellent. I really like that your textbook put this in there, because we may know people in our lives or even our patients, and somebody will say, well, they have Alzheimer's, but you kind of wonder, is it mild? Is it severe? What type of Alzheimer's it is? And it's important to know this, class. So be sure you know the stages of the progression of the symptoms, and think about what kinds of nursing actions or things that we can do to help these patients in each of these stages. Truly, it's all about how we can care for them and what we can do to help them. Remember, we want to help them to maintain their independence as long as possible. However, for safety issues, this is a big thing to be familiar with. So great job. I'm really glad you brought this up, and it's probably one of the better figures, in my opinion, in this chapter for sure. I'm glad you noticed
Just
that.
to add on, oh, sorry, go ahead, Amber.
Sorry, Kayla, go ahead. I'll go after you.
Oh, I was just gonna add on that the suicide risk is increased in the first, like the mild stages, because they're like aware of the cognitive changes. So that's something important, just because in clinical, I feel like I had a patient that is starting to just decline, and like not able to remember things, and she's like getting depressed because of it. So I would just try to be optimistic and shed some light, because it's really sad, and then especially if they're alone on top of that, it's like, what do they have else, what do they have to live for? And that's what she's like told me a couple of times, and it's like just really sad and heartbreaking. But yeah, it's just the depression and suicide is happens in like the early stages of it.
Absolutely, because then they actually are thinking about what potentially is going to happen, because remember, there is no cure for, unfortunately, this form of this dementia is not curable, and so we do see an increased risk of suicides because of that. Good job. All right, did someone else? Amber, were you going to say something?
Yeah, I was just going to say this chart, like you were saying, why it's so helpful. I remember in my first clinical, I had a patient in the hospital, and like I kind of knew but didn't, but I was like, she was diagnosed with Alzheimer's disease in her chart, but I was like, what? She's like had no issues at all. So I was like very confused, and like I was trying to like understand the differences and like how she could be diagnosed with Alzheimer's and have no impairment, like that was visible. So like I researched it at the time and stuff, and I found a lot of stuff that explained it to me like this chart does, but not as organized. So the chart is really helpful in seeing that like the patient can be diagnosed with Alzheimer's, but you really won't be able to tell sometimes.
Absolutely. Oh, so one thing to kind of remember is that changes in age, sometimes older people may, forget where their car keys are on occasion. We all do that, right? Or maybe put, something in the refrigerator which is not supposed to be in the refrigerator. That does not necessarily mean that they're developing dementia or Alzheimer's disease, because it happens from time to time. But constant self-reporting of memory impairment, that's definitely, if they're saying it, I can't remember, a lot of things, and the big pieces, that could be a sign of Alzheimer's. But just a little bit of forgetting things if you're tired, even young people, forgetting a little something, maybe you're exhausted or you're overworked or something like that, or involved in so many activities that things are forgotten. And again, it's not necessarily Alzheimer's. So not everyone who has those memory impairments would be diagnosed as an Alzheimer's patient. All right, that's really good. I really like that. Class, please know that, because I will test you on that. Okay, I think it's important to know. All right, great job. By the way, that circadian rhythm, somebody, whoever was reading that, a circadian, what is the circadian rhythm? Do y'all remember?
Your sleep cycle?
Yeah.
Yeah.
That sleep-wake cycle, yeah, circadian rhythm.
I think I was
Yeah, very good. The other thing that I noticed was really good and I enjoyed was the prevention and management of sundowner syndrome. The management, there you go. How did you know I was going to say that? Wow, that's pretty cool. So go to that slide for prevention and management. I think it's on the next slide or two, I forget. These are great examples of how we want to take care of our patient who has sundowner syndrome. Right.
Are you talking about like the five tips that was on there?
That as well. 5 tips was really good as well. That was for like communication.
Okay.
But this slide is really, really good, as well as your tips for communication for those patients and how we bathe those patients. How would you bathe someone with sundowners or someone who's got even dementia? And so it takes a lot of patience and being calm and keeping them warm. Those things really makes the difference when we are trying to bathe them. So sometimes you'll notice if you work around different types of nurses and techs, that if they're in a hurry to give a bath, particularly to someone who has a mental condition like this, how does that patient react? Kayla, I see you're shaking your head.
Yeah, because I've seen that so many times. They just get like anxious and they get like just kind of like irritable. Like, I mean, they don't want to be rushed, like, especially because they can't rush. Like, and so it kind of, I don't know, I feel like it stresses them out.
Absolutely.
When I, see it, and they just get like frustrated kind of, and like, you should have them like bathe, like if they don't want to bathe how you were going to bathe them, like I would just try to like offer like alternatives or, just to like at least maintain the hygiene. Like maybe it won't be like a complete bath, but, at least wiping them down, and just kind of like whatever their preference is.
Absolutely. Because you'll notice when trying to get these types of patients into the showers or even to the chair, they're constantly fighting like this because they become so anxious, like you say, Kayla. So we have to be really, really gentle with them and take it slow. All right, so important to remember those nursing actions for not only the sundowner, but also for your general patient of dementia. Okay, that's really good. All right, and the Kahoot game is cool. Yeah, there's that slide. That was a really good slide. Talk softly, be patient with them. That's a great slide. And the Kahoot game was very thorough, and I appreciate it. So, classes, any questions about this before we take our break? And then we'll be returning to talk about a quick overview of mental health disorders. It won't be very much in depth, but just a few things before we do our pain and comfort discussions. Any questions for this group? You did a good job. Give yourself a hand.
Thank you.
Thank you.
Absolutely. All right, well done. Oh, by the way, be sure to go ahead and upload it into the discussion thread And polypharmacy, those of you that had did that one, be sure you're uploading that. I will send it to students, but I'll also need it in that discussion. For some reason, I went to your side to look on the student side, and I noticed that I can't open it on the student
I
side.
can't open it either.
Right. And so I have to find out why, because I can open it on my instructor side.
Yeah, it
So
said
what
it's like an unfile or it's like not a
yeah, I
file
don't know.
or
I'm
something.
going to have to inquire, and I haven't had an opportunity to do that, but I will as soon as I can. But what'll happen once you put that up there, then I will send it out to students uh, along with my voiceovers of the chapter. So you will have that like I did for these past chapters.
Okay.
So
Thank you.
please just go ahead and upload it there, and I'll see if I can find out why. It must be just something small. It can't be anything major. All right. All right. Good job. So it is 11:59. Let's come back at 11, a quarter after. No, 12. I'm sorry. It's 11:59. So come back at 12:15, and we will continue on with mental health disorders, chapter 29. Okay? See you in just a few minutes. All right, class, we are back. Again, thank you for that wonderful presentation this morning, group. You did a great job. So for the next 20 minutes or so, maybe a little bit longer, we're going to talk about mental health. This is chapter 29. Class, I do recommend that you are reading your chapters. These are small chapters. And a lot of the material that's in the chapters is testable. It's all testable, but I'm thinking that also because you just also recently had mental health, it should be, you know, kind of familiar with you because of your recent relationship with mental health. So let me go ahead and share my screen. All right, you should hear, or you should see actually, chapter 29, mental health. There's lots of things that we could talk about in mental health, but again, your chapter is fairly small because it's only focusing on 3 things that we're going to focus on. Basically, is depression, anxiety, and of course, substance abuse. So let's get started. Some terms that it's important to know, of course. There's only 3. There's not a whole lot as far as terminology. I think the one here that's really important at this point is really substance abuse. And substance abuse can be many different substances. It doesn't have to just be alcohol or drugs, illicit drugs. It could also be, you know, tobacco, as it mentions here. So I think that term is probably the one that I would be sure you know. And we'll talk a little bit more about that as we get to that subject matter. So looking at mental health, we do know that for our patients to be able to take care of themselves in their older state, that throughout their lifetime, they have been able to deal with many of the problems that they have emotionally in their mental state. However, we do know that depression is the most frequent mental illness treated in older adults. And I like what the group said this morning about the patient that they were seeing as their case study, where the patient was possibly depressed, and suicide is one of those problems when they become depressed. It really increases the risk of depression, of suicide. So the most frequent mental illness for the older adult is going to be depression. Now, you might know some older adults who are, say, living alone, can't get out very often for many reasons, physical or financial, or they can't drive anymore. And so they really do need some interaction with other people in order to feel important, to feel needed. But we do see a lot of depression in our older population. Mental illness is about a 20% of all suicides. That's a pretty high number. That's a really high number. So out of 1,000, say, people, older adults with mental illness, 20% of those would account for suicides. And that's a big number. And we have to always remember that for our patients with mental illness. The other thing what we do notice as well is that besides suicide, the older person wants to really try to help themselves to get through their old age. However, they need to have some kind of exercise and ability to control their future. And that becomes an issue if they do not have the financial means of doing that, or ways to get to the doctor or to see mental health counselors. But we do know in general that the mental health that a person has had over their lifetime is usually what's going to happen in their old age. We've heard the term, when that person got old, they just became mean. Well, it's not necessarily that they became mean because they got old. It could just be that maybe they had a mean streak in them when they were younger. And so we do want to follow that with all of our patients to see how they are, their mental state is throughout their lifetime, and then it makes a huge difference. Now, granted, because of the age-related changes, remember the brain has less blood flow. We know the brain has less weight. It actually atrophies. That could also affect that the mental illness and some, cognition issues as well. But we do know that mental health practices, the use of coping mechanisms and defense mechanisms, and in routine health cares, those things really do help our patients even as they get older. So emotional homeostasis really, as I've kind of mentioned this already about the coping mechanisms, most of our older adults know who they are. They do know what they want out of life. Most of them are really happy with their life, and they expect to have some productive years, say after they retire. But many of them, interesting enough, all humans go through periods of trials and challenges in their life, and so they have overcome many of those problems in their life. So they actually learn from that. And so that's one of the things we like to ask our patients to tell us about a life story. How did they overcome a particular situation? Let them do a lot of talking, because if they're getting into if you're taking care of them as an older person, some of the things that had happened to them in their younger days, and they got through it, and they were able to cope with it, they were able to deal with the stress of whatever that situation was, actually helps them when they get into that older age time frame. However, stressors can actually add to mental illness, and we'll talk a little bit about that. So there are many myths that are around the older adult. For instance, as I mentioned, senility. We hear that all the time. They're old, and now they're all crotchety old man, or woman's not very nice. So we do know that that is a myth. Senility does not necessarily mean that they're going to all become those types of people as they get old. All right, senility is really a myth, okay? That they're mentally incompetent. That's absolutely not true. It is a myth. Our older patients have pretty sharp minds. There are some changes related to ages, but it's to be expected. Some patients do develop the dementias, as we talked about today, but in general, getting older does not make us mentally incompetent. And they don't turn into children, like they act childish. And no, that's not true either. 90-year-olds, 100-year-olds, they can out there be acting just like adults. Some of them still work. So again, another myth. Being rigid and cantankerous, which we've kind of mentioned already. Obviously, that's also a myth. That's not true. So we need to think about what's causing some of these misconceptions. Sometimes we have to think about the pathological signs and symptoms that may be overlooked. Maybe there are some things that are causing some of these changes in their mental state. And some of these are going to be normal agings. But we also have to remember that as nurses, we need to be able to identify, is it a normal aging process, or is it some kind of pathology that we need to be concerned about? And nurses also fail to intervene timely. Well, that's not really necessarily true. These are misconceptions. Nurses do tend to be very observant and able to pick up on some of these unusual, bizarre behaviors before it gets out of control. And of course, our role is to identify those, come up with plans of care, and of course, notify the healthcare provider if we see anything. 1 in 5 older adults experience an incident of mental illness. All right, that mental illness can be many things. It could be depression. It could be some other pathology. But 1 in 5 or some substance abuse. That's another one, 1 in 5. And so 2/3 of the nursing home patients demonstrate mental and behavioral problems. So we have to think about the stereotypical and making sure that we're not stereotyping our older patients, but maybe there is something physical going on with the patient that's causing some of the behaviors. Okay. All right. Okay. Whoops. Oh, I went backwards. Sorry. So we want to promote mental health, of course. We have to stay away from the stereotypes, obviously. We need to help our older patients stay active, enjoy the things that they enjoyed when they were younger. In other words, activities, things that they can actually do, interests that really make them happy. You know, if they like to do puzzles in their younger day, maybe they can do puzzles in their older day. So as nurses, we want to encourage patients to do as much as they can that they enjoy doing. And so that's what we do. And of course, physical health is obviously something that we have to take into consideration as well, and want to make sure that our older adults are getting the care that they need, and routinely meeting with their healthcare provider and looking at the medications, making sure that they're not having any issues with those. So we do recognize that sometimes there's things that are going to happen for our older patients that could cause them not to be able to deal with the stress or deal with the problems that are in their lives. However, we will help them get through that. We will be able to hopefully be able to identify those problems, let them tell us all about them, and see if we can come up with some kind of resources if they need. But we do want to not forget that it could be sometimes even older adults are going to be stressed out and might need some help. And that's what we're here for. There are some mental health challenges, of course, for our patients in general. And you can see the problems here. Illness can cause a lot of major issues with our patients. Their physical state, death of a family member or a spouse or a lifelong companion can actually change the mental health status of an older person. Retirement, we've talked about retirement in the past, just a few weeks ago actually, about how retirement can change an older person's lifestyle and how they have to look at the phases and the stages of retirement, and to see how they are going to be able to manage all of that. Our older patients are definitely vulnerable, not only for scams on the telephone or through the mail or people knocking on the door, but they are very vulnerable for potential abuse from others, whether it's relatives or friends or even strangers. So they are very vulnerable. They are considered vulnerable populations. That's important. Many of them are socially isolated for many reasons. Many just don't have another spouse. They don't have a lot of family. Maybe their friends they don't have a lot of friends. But there's lots of reasons why a patient is isolated. But that is a major issue in this population, social isolation. Sensory deficits also cause problems with their mental health. We've talked a lot about sensory deficits where they can't hear very well or they can't see very well, and it causes them to become a little bit more isolated from others, maybe perhaps from embarrassment that they're not able to hear, and maybe they don't want to go out with their friends because of that as well. So sensory deficits definitely can cause mental health problems for our patients. The other thing is that I like the last one here, greater awareness of own mortality. And of course, that increased risk of institutionalization, dependency, that's kind of a fear for many of our older adults, fearing that they'll have to go to a nursing facility, they won't be able to take care of themselves, maybe they don't have family that's willing to help them, strangers are going to touch them. So that can be a horrendous fear for our elderly population. And they also realize that their life is coming to an end. And sometimes patients or older people do have difficulty accepting the fact that they're going to die. However, it's kind of forefront in the mind that life is ending or will be ending. You don't see that as much in younger people because they have all those years ahead of them. So let's talk about depression as one of our mental health conditions. It is the most frequent problem that psychiatrists treat in older adults. There is minor depression. In other words, the patient may have some depression and they will develop some more depression as they get older. But what I like, the percentage here is pretty good, 15 to 25% of depression in community-based older adults. That's a high number. But look at the percentage of patients who are depressed in long-term care facilities, 25%. And 20 to 30% of nursing home residents display the symptoms of depression. And so it makes sense when you're working in a long-term care facility to be on the lookout for patients that are become depressed, where they don't want to speak to anyone, where they don't want to talk, they don't want to interact in the activities. It could be from, say, for instance, that age-related problem, but it also could just simply be that they are depressed and saddened because they have to be in a long-term facility. Things to consider. Again, some patients have depression their whole life. What is interesting, it's not uncommon for depression to be a new problem in old age. It could be something new. And look at all the losses that the older adult faces. Their children are gone, they're grown up, some of them don't live close by, they don't get to see their grandchildren. That can become very depressive. We've talked about retirement. Perhaps they're no longer working, so they no longer have a place in society as far as a role. Or maybe they were in a leadership role and now they're not working anymore. Those are losses and can be very significant and impact that older person for sure. A reduced income obviously can affect them, their ability to get around, to go on vacations, to even eat properly, and meet those basic needs. The body doesn't work as much as it should. I mean, as good, I should say, as it should. And of course, that can lead to depression. Self-image, the body does not look as healthy or as pretty as when they were younger, and that can be a source of mental anguish for many people. We've talked about death, and of course, the lifespan is now shorter, and that can lead to depression if the patient is not able to accept that. So there are many, many, many losses that the older adults face. So what we have to really do is actually look at how do we assess if an older person is depressed. And on page 416 in your textbook, it's a box 29.2, is a depression scale. And let me go to that real quick so I can tell you what I want you to know. All right, 416. Yes, it's basically a short form of the geriatric depression scale. And what we have here on the next slide is actually the geriatric depression scale assessment that we're going to watch for the rest of the class time. This is an important video to understand how do we assess an older patient's depression. How do we know if they are depressed? So you have the access to this video as well, but I've already pulled it up because I really want us to watch this together. All right. Can you see that? Can y'all see my screen here?
Yes, ma'am.
Oh, awesome. Oh, I hope you can hear it. Oh, I hope you can. I might have to get some help with that. But anyway, so let's go ahead and watch this geriatric depression scale assessment. So this may run into 1 o'clock, and so we're going to be finished. We won't continue on after 1. But I want you to be sure that you're going to be watching this. So let's go ahead and do that. Can you hear it? Can you hear it, class?
No, ma'am.
Can you hear it now?
No.
You cannot hear that.
No.
All right, hang on a second. Let me see if Jose is available because I really want us to watch this together, and I don't know why, because it sounds fine on my end, but there's got to be some reason why you cannot hear that. So if you don't mind, would you mind just a second? Let me just see if he can come, because this is a really important one. Don't want to hold you up too much, but I want us to watch it together and we can talk about it. Okay, let me see if he can come real quick, class. So while I'm waiting to hear from him, on the geriatric depression scale on your page 416, there's just some questions that the nurses can ask. This is a very common scale, by the way, the geriatric depression scale. And it asks things like, are you satisfied with your life? It's a yes, it pretty much is yes or no. All right. Do you get bored often? Are you afraid something bad is going to happen to you? So it's really it's like 15 questions that can be asked to our patients. And then there's a scoring mechanism that goes along with that. So a score greater than 5 would suggest depression. Now, of course, they have to be monitored and talk, psychiatrists and all those things. But it does give us an idea if there is a potential for them to be depressed. So let me see if has not responded yet. Okay. So while we're waiting, I'm just going to go on, but I don't want to. All right, so while I'm waiting to hear from him, I'm not going to pull my slide down. I'm going to leave it. So we're going to be on number 13. We're going to go ahead and continue on. If you can see your slides, that'll be good. All right, the signs and symptoms of depression are very important to know. Please mark that, okay? The most common manifestations of depression, they call them vegetative symptoms. Right. And what that means, the patient becomes very fatigued, they're anorexic, they don't want to eat a lot, they start losing weight. Okay, well, Jose will not be able to be here. He is out to lunch. So I'm going to put my slide back up and we'll watch this next week. Let me tell him that. Sorry. There we go. All right, I'll just tell him we're done at 1 and maybe he can come and help me when you're gone. So let me get off of here then. All right. But this is the website that you will go to. It's this one right here. Okay. And it is at the, geriatric consulting firm. Okay, so we're going to move on from this since you're not able to hear it at the moment, but I'll get it fixed. Okay, so again, vegetative symptoms, no interest in sex, those types of things. Of course, the expressions of what the patient feels like, they're guilty, they're remorse, they're hopeless. Those types of feelings can also be common manifestations of depression. They lose interest in other people. Their personal relationships, kind of go down. They don't like to talk with anybody. And so they have no interest in other people at all. Maybe their sleeping patterns change. Maybe they do a lot of sleeping instead of getting up and about. They don't take good care of themselves. In other words, they have very poor hygiene. They don't take a bath like they should. They neglect themselves is what they do. They can complain of headaches and indigestion. That's also another sign and symptom of depression. And then, of course, there may be some issues with their thinking ability because their nutrition is so poor because they're anorexic and they're not going to eat anymore or don't want to eat. So those are the basic signs and symptoms of depression. It's important to know those, so please mark that, right? So when we are doing a mental health assessment, and you're going to see that in the video, that's why I'm definitely going to show that video maybe next week, since Jose's not able to help us today. So the mental health assessment, we want to be very matter of fact. We want to approach them like adults. Okay, we want to be very positive and reassuring to our patients. Make sure we do the eye contact appropriately and talk and speak appropriately as far as how we speak to the patient. We don't talk to them like they're babies. We don't use the baby talk. We don't say sweetie and honey and all of those types of lingos that we have heard in the past, I'm sure. Remember, because the slowness sometimes of the ability to think, to get their thoughts together, we may tend to want to rush them when we are talking with them and assessing them, but be sure we give them plenty of time to respond to our questions, right? Of course, we always establish rapport before we even begin an assessment. That's true in nursing in general. We always establish that rapport with each other. And of course, we want to make them comfortable. So assessment begins when we first meet the patient. So here's some things that you're going to note. Are they dressed? How are they dressed? Are their clothes clean? Is their hair combed? Is it fixed? How are they standing? Are they all slumped over? No. Do they stand upright as much as they can if they have some type of kyphosis? However, we're really looking at their posture, their movement. How do they move? Do they look confident? What about their facial expression? Is it kind of sad looking? Is it mask-like? And so we're observing our patients here. And of course, their level of consciousness is important. How they speak to us, their tone of voice, can they articulate? Do they have weird words? In other words, something really strange? Are they speaking where it makes sense? And of course, we have to look at their mood. How are they feeling? Are they complaining? Are they wandering around the room? What is their mood? Are they upbeat? Are they happy? Or do they appear to be happy? So be sure your observation skills are so important for mental health assessments. So we have to ask direct questions, okay? And some of these questions are also what we would see on the geriatric depression scale, what I mentioned in your textbook and what we're going to watch in that video. So these are some questions that you could ask them, and we need to be direct. How do you feel about yourself? Do you have any friends? How many friends do you have? Are you Are you moody? How's your appetite? So we ask them direct questions in order to get as much information as we can about their mental health. The question about, have you ever thought about suicide? Sometimes nurses are afraid to ask that question, but it's very important. So whenever we're talking with patients who have suicidal thoughts and ideologies, remember, we ask them directly, are you planning on killing yourself? And if you are, how are you going to do it? So we need to be direct, even when we're doing a basic mental health review. And so I've listed a whole bunch here for you to be sure you're familiar with. And so there are, remember we did the mini mental status exam before. We talked about orientation, their memory retention. There's things that we can ask them to do. Give them a couple of nouns, animals, fruit, whatever you'd like to use, and see if they can remember it in about 5 minutes, how long they were able to remember that information. The 3-stage command, tell me in 3 ways how you would move from this chair to the couch. So we asking them to think through a process. And of course, what is their judgment? And can they do calculations? Are they able to do basic math, multiplication or addition? So we've learned that way back at the beginning of our course. But if you don't have a specific tool, then you can use this. But I do believe that one of the best ones to use is the mini mental status exam, and of course the geriatric depression scale. And we just have to get to know our patients as well. We always say that. In addition to the cognitive testing of our patient, we have to do a physical exam. You're familiar with doing a physical exam, so we won't spend a lot of time on it. But sometimes if a patient has got some of their electrolytes are off balance, or maybe they're having some kind of pain or discomfort, those could actually change their cognitive ability to think. And so that could be the issue why we think they might have a mental problem, but when it really is something to do physically. So we have to do a really, really good mental health physical exam. Be sure that we are reviewing all of their diagnoses and their medications because of those interactions between the medications. There's some lab values listed here. Be sure you know different lab values and what these mean. It's important to know what they mean, obviously. Sometimes other tests such as CTs and EEGs and CAT scans, etc., might be important based on what the findings are, and that would be up to our healthcare provider, of course. But our initial physical exam will give some more information as to how much more testing that should be done. And again, yes.
Regarding like the psychosocial like development,
Yes.
like Erickson, how do we? Do you have any like? How do you know what stage that the older adult is in? Like if they've made it to integrity versus despair?
Oh, there's not really stages, but you're asking me how do you know if they're in integrity versus
I just
despair?
remember like assessment when we had to identify like what stage that they were, like what psychosocial stage that they were in. And I know that that's like the final one on Erickson's is like the integrity versus despair.
Right.
So I was just curious as to how you would do you ask?
Well, you can
general questions.
Yeah, remember the questions that we just asked our patient. Here, let me go back.
That will help us answer that.
Yes, absolutely. So these are some of the questions. For instance, are they, when it says, "Does life bring you pleasure?" and they go, "Oh yes, I go to church every week, and I go out to lunch once a week with my friends." Right now, that's telling us something good, right? No, they don't consider suicide. I'm just telling you what a patient might say. Oh, I eat everything. That's why, I gained a little weight. I really enjoy eating, and I love being around my friends. And no, I've really never had any problems, mental health issues. I've never been treated for anything. That tells us that this patient now has reached that Erickson stages of integrity, that they're feeling, and of course there's other things too, but yes, that they are doing okay, that they've reached that stage. They're accepting they're old, they're accepting that they're older. So there's lots of things that you look at to determine if a patient is in despair. Somebody who is depressed is not going to be an integrity stage. Does that make sense?
Okay, thank you. Yeah.
Yes. So that was a good question, actually. All right, so integrity versus despair. Absolutely. Okay. So the last thing on here is to keep in mind, remember we talked about the cerebral blood flow. We have to remember that, and remember their body temperature. They're not able to, their body surface really, they chill easily, so they lose a lot of heat. And so we have to remember their body temperature is going to be a little bit different from when they were younger. Their blood sugars might be a little bit different as well. So we have to keep those things in mind when we are doing a physical exam on an older patient. So we're going to do a health assessment. We're actually going to do a mental assessment on the patient with those questions, or very similar type questions. We're going to do our physical exam. And so then the healthcare provider can, of course, determine what kind of treatments if needed. All right, they may not need anything for treatment. But just a couple of things your book brought out about treatments. You can see here. Sometimes medications can help if they do have depression, if they have developed those symptoms that we just spoke of. Electroconvulsive therapy. I think y'all learned that in mental health, right? I think y'all probably covered that in ECT,
Yeah, we did.
Yes. All right. So sometimes they have to have that if necessary, but that's really serious. And of course, we're not talking a mental health course here. We're just talking about things that could happen for your patients. St. John's wort. We do know that St. John's wort is really great for mental alertness. However, with antidepressant medications, we really probably shouldn't be using that or giving that to our patient. And there's other types of treatments that can be done that are non-medical or non-medication, I should say. All right. And of course, taking care of their nutrition and exercise. All right, so let's talk about the antidepressants. So here's a whole list of antidepressants, and let me show you some things that are really important here. We can take our patients, sometimes have to have some of these. I'm sure you've seen these in pharmacology. All right, and there's multiple types here. The MAOs, I's actually, I forgot the I there, sorry. There's a few here we can use for antidepressants. But the thing here that I think is real important is start low and you go slow with dosings. And you've probably heard me say that a few times when we were talking about medications. Because really for the older population, because of their liver, potential changes in the liver, we want to go start kind of low, and then the doctor will not over medicate them too soon. So the big thing is start low and go slow with dosing for really all medications, but particularly with our antidepressants. And it takes about a month for these really to take effect. And we give them normally at bedtime because they make you sleepy. I'm sure you remember that. There are some side effects for antidepressants, and I've listed those here for you. Dry mouth, diaphoresis, photosensitivity, and those. So you can take a look at those. So for your antidepressants, I'm not going to ask you specific questions on each of these. You'll get that in pharmacology. But just know that when we are giving antidepressants to our older population, we're going to start with a low dose. and then gradually increase it if that's necessary, depending on the how it's affecting the patient and how their symptoms are progressing or getting better, right? Takes a month for therapeutic effect, of course. Give it at night, preferably, because of the sedative effect, of course. And then be sure you know your side effects for antidepressants as a general category. All right. All right. All right, I have 12:55, so I'm going to stop here. And so the next one will be talking about suicide, a little bit on suicide, because so there's lots to talk about that, but we'll only talk a little bit about what your book has in it. All right. So does anybody have any questions about what you learned, or just really what you just reviewed? We had great discussion on dementia and Alzheimer's disease and delirium. And so that was really good information to know. And then this short chapter here, we just started talking about how does it affect our clients? What can we do to assess our patient? How will we assess a patient for mental depression, right? And a little bit about your antidepressants. Not a whole lot on that. Any questions? No, I don't hear any questions. Y'all are quiet today. Here, let me go ahead and.
We're tired.
Oh, I know. I've heard y'all say that. I know. I can understand. I'm trying to find y'all. Here. I have to get rid of this here before I can see you. If I can get done here, for some reason it's not letting me get to you. All right, here we go. All right, so I just see a piece of you there. That's good. At least I get to see someone. All right, so if you don't have any questions, I think I'm going to end the class. And again, I will get with Jose to see why you can't hear this video. You're more than welcome to watch it, later. I mean, if you want to, because it's available for you. But I really wanted us to watch it together and then kind of talk about some of the actions and how those nurses approach the patient. It's a real live patient they're talking to, and I think it would be really good to see, because you've done so many patients that you've done a lot of physical assessments. You've done all of those types of things in clinical, but the mental health assessment and the geriatric depression scale is a little bit different, and it is really a great way to assess our patients for depression. And I want you to know how to do that when you get out there in clinical, or when you get out there to be a nurse. Okay. All right. Well, I hope you get some rest. Do you have any more tests this week? No? Okay. Well, that's good. All right. So some of you may be off tomorrow. Do you have clinical Fridays?
We have sim tomorrow.
We have sim, and then we have the open lab for our checkoffs on Tuesday.
Oh, is that when the checkoffs are next Tuesday? Okay.
Yeah.
All right. So I know. So maybe for the rest of the day, just try to get some rest if you can. And we'll be in touch again. Okay.
Thank you.
Yes. So what I'm going to do here